So to begin with, I have two abstracts, as she said. The first abstract is proton flash radiotherapy for the treatment of symptomatic bone metastasis, the FAST-01 non-randomized trial published in JAMA Oncology. So you all know that unique biological effects of ultra-high dose rate radiotherapy delivered at more than 40 gray per second, now known as flash therapy, was first reported almost 50 years ago. So to date, only one published case report of flash therapy in human, that was for the extensive cutaneous T-cell lymphomas. Extensive priority therapy to the skin was safely and effectively treated. So this led to that discovery, and then they started a prospective non-randomized clinical study to assess the workflow, feasibility and clinical outcomes of proton flash therapy based on the extensive preclinical data suggesting that there is some benefit or clinical efficacy in this treatment. So this was three painful metastases in the extremities were evaluated for enrollment. Eligibility criteria was 18 years or older, no prior radiotherapy or intended to treat target, and the life expectancy was not more than 2 months. And patients were excluded if the tumor lysis was more than 50% of the circumferential bone cortex, and there were fractures or metallic implants, and also if patient had undergone cytotoxic chemotherapy, they were not taken up for flash therapy. So there were only 11 patients enrolled, ultimately 10 were treated. Median follow-up was 4.8 months, pretty small. Patient age ranged from 27 to 81 years. And there was a spectrum of histological diagnosis, probably NSLC most common, then followed by breast and multiple myeloma. And all treatment were delivered at a flash dose rate of 51 to 61 gray per second at 5 centimeter depth. Mind you, what we treat in our linear accelerator is almost 0.03 gray per second. So the elapsed treatment time the patient spent on the treatment couch was on average 15.8 minutes per treatment site and 18.9 minutes per patient. So the flash treatment sites, these were the most common: femur, humerus, and tibia. And if you look at the adverse events, obviously skin pigmentation, that was grade 1, almost 4 out of 40%, out of 40 patients. So this was the first non-randomized trial in humans showing minimal toxic effects and desired therapeutic benefit for most patients. Based on the clinical workflow, efficacy, and safety data, it can be concluded that ultra-high dose rate proton flash therapy is feasible in a clinical setting. Future clinical trials of proton flash should extend these findings to other body parts to demonstrate applicability of this technology to multiple cancers. Now moving on to the discussion. So this was, as I said, this was the first study of flash RT in patients with bone metastasis, and were selected expecting a likely to receive benefit equivalent to the same treatment with conventional dose radiotherapy. And the choice of workflow feasibility as a primary endpoint was selected in recognition to validate the complexity of the new modality of this treatment. And flash treatment occurs in milliseconds. So you need to be more vigilant in, that requires very vigorous validation of beam delivery, advanced dosimetry, QA, patient positioning, lot of work for the physicist in fact, and delivered gray is almost 40 to 50 gray per second compared to 0.03 gray per second. So the study was basically not powered basically to evaluate the pain relief as a primary objective, but they focused on how efficiently they can do it in a busy department. And the rate was comparable almost with the outcomes of 8 gray single fraction conventional dose rate radiotherapy administered for painful bone metastasis based on the RTOG 9714 trial. And the strengths, of course, included the prospective design, meticulous tracking of adverse events, and a thorough workflow analysis. But they failed to show, in terms of limitations, it was just 10 patients who were treated, and the treatment sites were limited to extremity bone metastasis. So take-home message: flash RT, a prominent new technology giving minimal toxic effects, desired therapeutic benefit, and the trial has shown the clinical workflow metrics, treatment efficacy and safety data, and concludes that ultra-high dose rate proton flash therapy is feasible in a clinical setting. But again, the major drawback was the sample size, and only extremities were metastases were selected. We need more flash RT trials in other sites rather than only in palliative settings to firmly set this as a new modality over conventional photon radiotherapy. Moving on to the next abstract. This is a dose-escalated SIB radiotherapy in early breast cancer, that is import high, a multi-center phase 3 non-inferiority open-label randomized control trial published in Lancet. Now you all know that tumor bed boost delivered after breast radiotherapy increases local control rates but requires more patients visits and can increase breast hardness. So import high basically tested SIB, that is simultaneous integrated boost, against the sequential. Sequential is something you finish your radiation and then plan an extra dose to the tumor bed, while maintaining excellent local control and similar or reduced toxicity. So import high builds on the results of previous UK breast trials and uses newer radiation techniques like IMRT or IGRT to the lumpectomy boost cavity to address the challenges. So this was a phase 3 non-inferiority open label randomized control trial. Inclusion was PT1, T3, N0 to N3 diseases. And the control group received 40 gray and 15 to the whole breast, and the sequential arm was 16 gray 8. There were two test groups, test group 1 and test group 2. Test group 1 had 36 grain, 15 to the whole breast, 14, 15 to the partial breast, and 48 in 15 to the concomitant photon boost to the tumor bed volume, whereas test group 2, the difference was the tumor bed boost went up to 53 in 15. The primary endpoint was ipsilateral breast tumor relapse, analyzed by intention to treat analysis. So there were 2617 patients recruited, and if you look at the results, the median follow-up of 74 months, 76 IBTR events, 5-year IBTR incidence was 1.9 for the control group, 2 for the test group 1, and 3.2 for the test group 2. And the estimated absolute differences versus the control group were 0.1 for the test group 1 and 1.4 for the test group 2. The upper confidence limit for test group 1 versus control group indicated non-inferiority for 48 gray. Now, this way the graph, you can see absolutely no difference, suggesting a non-inferior approach, non-inferior results. And the study achieved non-inferiority for IBTR in absolute terms according to the pre-specified difference of 3% for the test group 1 versus control, but not for the test group 2. It highlights the challenges of assessing non-inferiority when primary outcome events rates were very, very low. And the rates of 5-year moderate to marked adverse events are low, and 48 gray SIB showed similar or reduced toxicity compared to the control group. SIB is safe treatment that requires fewer patient visits, and further escalation of Bose dose does not have any advantage. So as I said, this trial basically had anticipated IBTR incidence by 5 years across all treatment groups within a population at a high risk of relapse. It was agreed that absolute 3% difference between groups and confirmed that events rates were low. There was no difference in efficacy endpoints between two groups, and 48 gray SIB delivered in 3 weeks in test group 1 had similar efficacy to sequential boost delivered over 4 to 5 weeks. And beyond 53, probably 53 grays in test group 2 had no additional benefit. So we still believe in doing 48 gray. And the only previously published SIB study with a local control primary endpoint is IMRT MC2 trial, and the other very good trial that was NRG RT OGs 1005, which basically had only two dose groups, that was 40 and 48 gray SIB. SIB is less burdensome for patients and their families, reducing travel cost, enabling return to work sooner. This method is an efficient use of resource for healthcare providers, whereby radiotherapy time slots can be used for their patients. And again, major drawback was limitation, unmasked events leading to bias, and other limitation was you're giving 36 gray in 15. You don't think about nodal radiation, you're just giving 36 gray to the entire nodal group, including the breast. So the take-home message, import high, we observed lower than anticipated event rates, adds complexity basically to interpretation of non-inferiority trials, given the relative effect threshold is defined according to the original absolute risk. And planning in import high is a complex process. I believe you're doing 3 levels, 36, 40, and 48 or 53. So evaluating all in one plan is going to be cumbersome. And SIB, if SIB was a goal basically, then simpler dosing like RTOG 1005 or in fact Hypot Adjuvant by TMC Kolkata had 5 days SIB is more simpler, attractive for low income and middle income countries, as many people would otherwise forego treatment due to traveling and accommodation cost for longer radiotherapy courses. Thank you.